Hello everyone, this is Dr. Madhusudan Rao and the program I teach medical students. Today the topic of my lecture is gait disturbances. Gait disturbances are very common in the geriatric age group. Nearly more than 80% of the aged people they may get disturbances in the gait beyond the age of 80 years. It is less common in younger age groups, but disturbance in the gait is a great risk factor for falls, injuries associated with morbidity and mortality. Today's lecture, we are going to touch on the basic principles involved in the gait, that is gait cycle. Then classification of abnormal gaits, pathophysiology of normal gait, and treatment and the prognosis. What is normal gait? Our normal gait is controlled by strength of your muscles, coordination of the muscular action, and sensory inputs. Okay. For you to walk normally, you should have the normal strength of your muscle. Muscle strength is maintained by the afferent and efferent nerve fibers. Okay. Afferent carries the sensory fibers from the spinal cord to the higher centers through proprioception. That is, proprioception is the sense of position of your body in the space. Okay, and signals reaching the higher centers, and your muscular strength and power is maintained by the motor neurons. Motor neuron nerve cells are located in the motor cortex of the frontal lobe, and they run downwards in the form of corticospinal tracts, ultimately innervate the anterior horn cell of the spinal cord. From there, they reach the neuromuscular junction through lower motor neurons. That means there is the network of nerve fibers in the form of upper motor neurons, lower motor neurons, and neuromuscular junction, ultimately giving the voluntary movement of the muscles. Okay. Injury to any part of the motor neurons can result in the weakness of the muscles, thereby causing the disturbance in your gait. Because for you to walk normally, you need the muscular strength and normal health of your joints. Okay, and muscle strength is maintained by the nerve fibers starting from the brain down to your muscle. Okay, ultimately it is the brain that controls your voluntary acts. Then, if the muscle is not receiving the adequate nerve supply, if there is injury to the upper motor neuron, the muscle will lose its strength. Okay, upper motor neuron lesions are characterized by the loss of power and increased tone, hypertonia, and exaggerated reflexes, and positive Babinski sign, and atrophy of the muscles. Okay. If the lower motor neuron is injured, there is loss of power and hypotonia. muscles are flappy. That is, muscles become weak with loss of tone. And there is the remarkable wasting of the muscles. Okay. So this is the importance of the integrity of the nerve supply is very much essential to maintain your gait. Next is coordination. For the voluntary movement to be smooth and properly executed, you should have good coordinating movement. Okay, it is maintained by the function of the cerebellum. Okay, because of the action of these nerve fibers running from the cerebellum to the higher centers, that is cerebral cortex. From the cerebral cortex, fibers run downwards to supply the anterior cells. That is the corticospinal fibers. In between, there is subcortical centers like basal ganglia, and at the brain stem there is a vestibular system. Okay, and there is visual centers. All these put together, they help to maintain the coordinated voluntary act. Okay, so this is a very complex neuronal network because of which we are able to maintain the normal stance and normal gait. Disturbance in any part of the neuronal network may result in the abnormality of the gait. Okay, say it is sensory, that is sensory fibers ascending from the periphery to the center. That is in the form of spinothalamic tracts. For example, there is posterior columns. They carry the sensations of proprioception, that is position of your body, is recognized by the higher centers. So when you are stepping your foot forward, and the brain knows the position of your foot, okay, and it has got the control over the movement, degree of movement, range of movement, thereby coordinating to carry out the smooth voluntary act. Okay. As a matter of fact, disturbance is in a subtle difference in the network of these nerve fibers can result in abnormality of the gait. The important thing is they should have the normal strength of the muscle. Muscle strength is maintained by the upper motor neurons. That is, motor neurons extending from the nerve cells located in the cerebral cortex down to the anterior horn cell. So that is the upper motor neuron. So injury to this part of the motor pathway can result in the loss of strength with hypertonia and hyperreflexia associated with mild degree of wasting because of disuse without any in the absence of fasciculations and fibrillations, which are the manifestations of lower motor neuron lesion. Lower motor neuron starts from the anterior horn cells down to the neuromotor junction at the target, that is voluntary muscles. Injury to this lower motor neuron will result in the loss of power with hypotonia and hyporeflexia. Okay, you can find the fasciculations and the fibrillations. Fibrillations are the recorded tracing. Fasciculations you can see in the muscle with lower motor neuron lesion. Coordination is brought about by the cerebellar function. So, if there is any lesion causing the damage to the neuronal network, it can result in the abnormality of the gait. Okay. So disturbance in the gait is said to be characterized by deviation from normal gait. Okay. Any deviation due to any cause from normal gait is called gait disturbance. And there are different names that are given based upon the way the individual walks. He may walk with the foot taking high stepping gait, or he may drag the toes of the foot. He may walk with the leg straight and arching around. Okay, so different names are given to the different types of the gait abnormality, which we are going to touch in the course of my lecture. It has numerous causes. Abnormality in the gait may be due to numerous causes, and the presentation is variable. So the doctor should have the high index of suspicion in order to make the diagnosis. Again, it is divided into chronic or episodic types. The gait abnormality could be chronic or episodic. Chronic gait disturbance starts insidiously and the patient has got the time to adapt to the abnormal gait. Okay? Whereas episodic starts suddenly and patient do not have the time to adapt to the abnormal gait and may get injured due to falls. Okay? This is the danger of episodic gait disturbance. That is, falls associated with the injuries are the risk factors for episodic type of gait disturbance. Okay. So to quote an example, freezing gait of Parkinsonism, fascinating gait of Parkinsonism, and disequilibrium gait are the examples of episodic gait. And the rest are all chronic gait disturbances. If the individual is suffering from gait disturbance, it has got a disastrous effect on the lifestyle of the individual because there is loss of personal freedom in order to carry out any voluntary act. He cannot move freely around, carry out his personal activities if there is disturbance in the gait. There is always fear of fall and insecurity that affects the lifestyle of the individual. So he suffers from depression, anxiety, great degree of morbidity, ultimately mortality. Okay. So causes of gait disturbance could be neurogenic or non-neurogenic. Okay. Neurogenic are more common than non-neurogenic. Neurogenic causes includes sensory ataxia, polyneuropathy, subcortical vascular encephalopathy, Parkinsonism, and dementia are the most common types of neurogenic gait disturbance. Osteoarthritis of hip and knee with painful limitation of the movement are the examples of non-neurogenic. So, with this type of introduction, let us go to the etiology. It is very, very important to know the cause of gait disturbance in order to treat the condition. Okay. Etiologically, they are grouped again neurogenic group and non-neurogenic group. Non-neurogenic are more common than, neurogenic are more common than the non-neurogenic. In this group, even a subtle disturbance in the communication between the central nervous system and the peripheral nervous system can result in gait disturbance. Okay? Because peripheral as well as central nervous system, they are connected together. They communicate with regard to the sending the signals and responding to the signals from the peripheral nervous system. The central nervous system responds to this and make the voluntary movements. So gait is the coordinated effect of signals received from the peripheral nervous system by the central nervous system. Okay, there are a lot of neurotransmitters involved in this, which will have the influence on the controlled motor activity. Say, for example, command from the central nervous system, that is motor cortex, to initiate the voluntary act, that is making the step forward, or cross-check and controlled by the lower centers, that is basal ganglia. So, and ultimately carried out by the cerebellar centers with great degree of perfection. Okay. The command is sent by this primary motor cortex and the cerebral cortex. They are cross-checked by the basal ganglia and ultimately executed in perfect way by the cerebellar network. Coming to the neurological diseases that cause the gait disturbance. So there are plenty, we'll make a few of them. That is, one of them is the Parkinsonism. Parkinsonism results in the abnormal gait, secondary to the rigidity, okay, hypokinesia, of the muscles because of the deficiency of the dopamine as a result of damage to the substantia nigra and the subthalamic nuclei. Okay, more so the pars impact of the substantia nigra shows the degenerative changes in the Parkinson's disease, thereby resulting in the abnormal muscular action. Okay, this is a movement disorder affecting the individuals above the age of 60 years. Okay, there is increasing prevalence of Parkinson's disease in the current years. There is gait disturbance associated with the rigidity, bradykinesia, and tremor. There is Huntington's chorea is the other one. Normal pressure hydrocephalus, NPH. So there is also slowness in the gait and disturbance in the gait, tendency to falls in this particular condition, which is common in the geriatric age group. Sensory neuropathies, that is the damage to the posterior columns, as we seen in the vitamin B12 deficiency, resulting in a subacute combined degeneration. There is loss of proprioception, resulting in the loss of balance and abnormal gait. While chorea, subcortical vascular encephalopathy causing the damage to the white matters, cerebral palsy with different types, that is spastic diplegia associated with the gait abnormality. Muscular dystrophies, secondary to the weakness of the proximal muscles, you may not maintain a stable gait. Spinal muscular atrophy, causing damage to the anterior horn cells, resulting in flaccid paralysis of the skeletal muscles. Ataxia telangiectasia. The name as such indicates there is disturbance in the gait. This picture shows the gait abnormality secondary to neurological involvement. Look at his stance. Stance is very important to maintain the momentum. If the stance is unstable, how can you make a gait? How can you walk when you cannot stand properly? So this becomes very unstable and insecure for the individual and develops a lot of anxiety and fear of falls. The other cause being electrolyte disturbances. Hyponatremia is associated with the damage to the nerve cells secondary to the cerebral edema. Hyponatremia causes devastating damage to the nerve cells, diffuse nerve cell death secondary to the accumulation of fluid intracellularly in the nerve cells. That results in the gait disturbance. In the same count, hypomagnesemia and hypokalemia causes weakness of the skeletal muscles. When the strength of the muscle is lost, you cannot walk properly. And then vitamin deficiencies. Vitamin B12 is associated with the posterior cortical degeneration and proprioception loss, resulting in gait disturbance. In the same way, vitamin E and copper deficiency are some of the causes of disturbed gait. Other causes being could be pain due to any cause in the muscles or joints, could be vascular, trauma, autoimmune diseases causing the myopathies as well as neuropathies, inflammatory vasculitis resulting in ischemic damage to the nerve cells, neoplastic and paraneoplastic disorders, and tabes dorsalis, the tertiary syphilis causing the damage to the posterior horn cells, thereby resulting in sensory loss and loss of proprioception, again resulting in gait disturbance. Psychiatric causes. So anxiety, depression can result in the abnormal gait, hesitation to walk. And malingering is another cause of abnormal gait. Well, what is the epidemiology? What is the degree of severity of this particular gait disturbances in the population? Neurological causes are more common in men. Non-neurological are common in women. 85% of the persons have normal gait around 60 years. Until 60 years, 80 to 85% of the people are having a normal gait. Okay. By 80 years of age, only 20% will have the normal gait. So why? This is the neuronal network and the impulses, signal system of the neuronal network becomes slowly dampened as the age is advancing. Okay. So the response of the motor neurons to the sensory feedback from the spinal cord are weak and dampened. So much so is the muscle strength and the coordination. That results in the disturbance in the gait. Okay? Because as age is advancing, there is reflexes are becoming dampened. So is the disturbance in gait. remember, disturbance in gait is the important factor causing falls and trauma and fractures. What is the pathophysiology? What is the mechanism of disturbance? We have already talked about it. And to repeat about the pathophysiology, pathophysiology of gait is complex phenomena. Okay, that includes to understand the gait cycle having swing phase and stance phase. Again, total duration of the cycle is variable depending upon the velocity of your cycle. If the cycle is faster, duration becomes shortened. There has been a description of 7 stages in the gait cycle. Okay. Gait cycle initiates with the striking the heel of the first foot and terminates with the second leg's stamping of its heel on the ground. Cycle starts with the one leg striking its heel, that is heel stage. Heel of one foot touches the ground. Then the second foot lifted off the ground on the toes and moves forward, and it makes its heel touch the ground. So from the touching of one foot, its heel on the ground, with the second foot moving forward and keeping its heel on the ground, is the duration of gait cycle. It has two components, swing stage and the stance stage. Well, posture is the most important component of normal gait. Your posture has to be normal and strong. You should maintain the erect posture, stable, then only you can walk forward. So posture is the most important factor of normal gait, which has got 3 important components. For your normal posture, there are 3 important components. What are they? Vestibular component, visual component, and proprioception. Okay, they coordinate each other to maintain the normal stance. If there is any disturbance in these circuits, you cannot maintain a normal posture, so you cannot walk properly. Gait initiated with flexion at hip of the first limb and second limb in stance. Okay, first limb stamps the heel on the ground and the second limb lifted off the ground stamps its heel on the ground, making a movement forward. Central nervous system has got the control of balance of the body. Okay, and the peripheral nervous system sends the feedback of information. Right? When your one foot in the heel stage, it is striking its heel onto the ground, and the second foot is lifted off. Okay, this is recognized by the central nervous system. That is, your position in the space is identified, and it will control your balance. Okay, your balance is maintained by the central nervous system while you are lifting off the other foot off the ground. And the first foot tone is maintained by the vestibular mechanism. Extensor tone is maintained, and you are stable to stand on one foot while you are lifting off the other foot and making it movement forward. Okay. This is the mechanism, and the disturbance in the neuronal network at any point may result in the disturbed gait. The diseases could be plenty. Okay, and the lesion could be involving your this. this neuronal network. Well, how do you evaluate the patient? You have to take the detailed history with regard to the causes, either neurological causes or the non-neurological causes. After taking the detailed history, which will speak about the pathology of the lesion, then identify the clinical signs, okay, classify the abnormality of the gait into is it neurological or non-neurological, then proceed with the perfect evaluation of the disorder and provide the appropriate treatment. Examine the patient while standing, so whether he is standing stable or not, and posture of the individual, stance, is it wide based or otherwise, how he initiates walking, and the way he is walking, step length has to be noticed. In certain disorders, step length is short and gait cycle is shorter. Okay, speed with which he is walking, arm swing has to be noted. It is slow in Parkinson's disease, and freezing, stiff walking, etc. Turning is freely or not. Tandem walking, that is, ask the patient to walk on a straight line with great toe touching the heel of the first foot. And blind walking, backward walking, Romberg stress, it will tell you the integrity of proprioception. Fast walking, toe walking, sometimes hopping, etc. Okay. This all clinical evaluation is to understand the neuromuscular integrity. Let us understand the gait categories. There are various types of abnormal gaits, and they will tell you about the neurological lesion or the musculoskeletal lesion, as a matter of fact. It could be musculoskeletal again or neurological, neuromuscular. The first one is the antalgic gait. What is antalgic gait? It is gait secondary to the painful condition. So the patient may be having pain at the ankle or pain at the knee or pain in any part of the limb. So his gait is abnormal. How does he walk? He takes care of the pain that is there with the limb. He will play more caution while making the movement of that particular limb because pain is hindering his movement. And the movement of that particular limb will be slow when compared to the normal limb. Okay. And there is a bit slowness of the gait. But individual muscle strength and then innervation of the muscle, that is motor nerve fibers are normal, reflexes are normal, reflecting the normal innervation of the neuromuscular junction. Okay, there is no injury to the upper motor neurons or the lower motor neurons or anterior horn cells or anything. There is a painful condition either at the ankle or at the knee or at the hip, thereby hindering the movement of that particular limb. Okay, that is the antalgic gait. Treat the underlying cause, provide the analysis. The patient is going to improve. Vaulting gait. Vaulting gait is normally seen in children when there is some shortening of the limb secondary to some disorders or by birth. There is limb is shortened. The shortening is more than 2 centimeters. It results in the abnormal gait. And he walks with hip drop because to reach the ground by the shortened limb. The treatment is surgical with limb lengthening procedures. Then coming to the neuromuscular causes, which are more common than the musculoskeletal disorders. In neuromuscular causes, I told you so many neurological disorders taken from the Parkinson's, Huntington's chorea, and the sensory neuropathies, etc. And what is the type of gait we see in these particular individuals? He may have the Trendelenburg gait. What is Trendelenburg gait? This is because of we have got the gluteal muscles. So we have got the gluteal maximus, gluteus minimus, and these gluteal muscles should maintain equal power in order to maintain the function of the hip while walking. Okay, if the power is lost in a group of gluteal muscles, okay, say the gluteal minimi on the one side is going to control the hip drop on the opposite side while the patient is walking. Okay, weakness of these contralateral gluteal muscles will result in the hip drop while is making the movement forward. Okay, hip on that side should be elevated by the action of the contralateral gluteal muscles. Okay. Say for example, there is weakness of the gluteal muscles on the right side. Left leg, the hip drops while making the movement of the other side of the leg. Okay. So right gluteal muscles are weak, left hip drops while making the movement forward. Right? That's how it is. That is called the Trendelenburg gait. High stepping gait. High stepping gait is because of the foot drop. To avoid the contact of the foot, instead of dragging on the ground, there is increased flexion of the hip of the deceased foot, deceased leg, and increased flexion of the knee to keep the leg off the ground. Instead of dragging the toes, he lifts the leg with increased flexion at the knee and hip. So that is the high stepping gait. Waddling gait. Waddling gait is again because of the weakness of the proximal muscles of the hip. Okay. To maintain the balance, there is wide apart. The legs are kept wide apart while walking. That is called broad-based gait. Scissoring gait is because of the spasm of the adductor muscles of the hip with hypertonicity of the muscles. Ataxic gait. It is unstable gait, secondary to the sensory ataxia or motor ataxia. Okay, so totally unstable. He is unable to maintain the balance of the body while making the gait. This is because of the either cerebellar lesions or the posterior column disorder. Okay, gait is very much unstable. He will be trying to make the movement with hesitation. There is fear of fall. Then there is ataxic gait. Hemiplegic gait. Hemiplegic gait is otherwise called circumduction gait because of the hypertonicity of the extensors of the knee joint. There is difficulty in flexing the knee, so there is complete extension at the knee. In order to avoid or clear the foot from the ground, he will make an arching movement of the foot or the leg away from the body. Okay, that is called circumduction gait or hemiplegic gait. Fascinating gait. This is seen in this shuffling gait or fascinating gait seen in the disease Parkinson's disease. The short stepping gait with the individual stooping forward because to avoid fall. Okay, and he stoops forward to maintain the gravity of center of gravity. Okay, makes his short steps. That is called shuffling gait. Apraxic gait is again the abnormal gait seen in the cortical lesions. I'll show some of the pictures showing the gait abnormalities. Well, this picture shows the person with Parkinson's disease. This is the individual with Parkinson's. He is stooping forward and there is shuffling gait, short step gait. This is the most unstable cerebellar gait within coordination. Okay. This picture shows chorioathletic or dystonic gait. There will be cerebellar gait. Okay. Gait of sensory ataxias. Stepping foot drop gait. These are only the abnormal gaits that have been mentioned here once again. Parkinsonism or fascinating gait. Waddling gait or sometimes called Trendelenburg gait due to the weakness of the gluteal muscles. Hemiplegic gait, which I told you already, it is sort of spastic gait because of the hypertonicity of the lower extremities, especially the knee flexors are weak. This is the gait cycle. You can understand the gait cycle, how it proceeds. It starts with the heel stage, right heel, see the right leg, right heel strike the ground, then left toe takes off the ground, left leg swings, left heel strikes the ground, right toe goes off the ground, right leg swings, then right heel strikes. Okay. In the grey color shows the right leg, black, total black color is the left leg. Okay. That's how the heel stage, toe stage, then various stages have been described here. This is the right leg stance here. This is the left leg stance. Okay. This is the various stages of the gait cycle. This again shows the various phases of the gait, showing the heel strike, then foot lying on the ground, flat foot stage, take off, then swing phase. That means gait as such is described in various stages, which has to be smoothly executed in order to maintain your balance. And it is a well coordinated act to maintain with a good balance of your body. So as we described the types of gait abnormalities, which is chronic or continuous or episodic or acute. Episodic category of the gait disturbances, we mentioned the freezing gait is one, and fascinating gait is the other one, and other one is the disequilibrium. This is the three important varieties we mentioned in episodic type of gait abnormality. Okay, the rest of the all causes are associated with the chronic gait disturbance. Okay, freezing gait. Turning is associated with hesitation. Tight quarters of hesitation. Hesitation while reaching destination. And hesitation during mental overload and stressful situations. Okay. So patient will be hesitant to make a movement. Hesitation for fear of fall. Insecurity to move around. So this is a very difficult situation and causing greatest disturbance in his lifestyle. There's no freedom of movement, you see. So that causes psychological injury and patient goes into depression. He will be confined to the wheelchair. He cannot move around. That's it. Fascinating gait is again is a disturbing situation that occurs in Parkinson's disease. Paroxysmal disequilibrium, characteristic feature of vestibular dysfunction. These are the most common causes of episodic gait disturbance. Okay, and the patient comes to you with history of falls. That's all. It is up to you to examine in detail, identify the cause of disturbed gait by examining his gait pattern. That gives you the clue, the type of the gait disturbance, and so the cause. Then in the chronic gait disturbances are associated with hemiplegic gait, antalgic gait, a painful condition, spastic gait again in the spastic diplegias, and also in hemiplegic gait, bradykinetic gait again in the Parkinsonism, hypotonic gait because of the lower motor neuron injury or the damage to the anterior horn cells in amyotrophic lateral sclerosis. And hypotonic gait is also seen in the electrolyte disturbance like hypokalemia and hyponatremia, etc., hypomagnesemia. And disequilibrium gait again runs in chronic disturbance associated with the vestibular dysfunction. Right. The psychogenic, the fear of falling. Okay. Then we can also see in the patients with the normal pressure hydrocephalus, also they have the gait disturbance. So look at this picture. These are the images of the footprints. The individual with normal gait, you see the duration of the gait cycle. Okay, duration of the gait cycle is very short in patients with normal pressure hydrocephalus. See, in a short period, he has made an hesitant short steps with short gait cycle. How many steps he made? 1, 2, 3, 4. Whereas in normal individual, he made 1, 2. Okay, these are 1, 2 cycles. 1, 2, 3 cycles. This is 1, 2. Yeah. Then, as such, the cycle duration is shorter in patients with normal pressure hydrocephalus, and it is also shorter in shuffling gait in Parkinson's gait when compared to the normal. Okay. So, if the patient is left untreated, there is always abnormal gait is a risk factor for falls and injuries, resulting in paralysis, fractures, sometimes syncopal attacks. There could be damage to the skull injuries, resulting in epidural or subdural traumas and subdural hematomas. And there is tremendous psychological stigma. These are some of the complications. Well, so evaluate the patient clinically and do certain laboratory work, imaging, to know the nature of the lesion and site of the lesion involving the neuromuscular disorders. Okay. So treatment depends upon the cause. Identify the cause as early as possible and attend to the treatment. Provide a perfect treatment after detailed examination and evaluation. It is a sort of the teamwork, okay, involving all the disciplines of management. Involve the neurologist, neurophysician, physiotherapist, social worker, okay, and monitor at each and every stage of your management. Okay, provide the vitamins and treat the mineral deficiencies. Monitor with the appropriate dose whether the adequacy of the blood levels of these vitamins are normal or not. Get to the normal levels of these vitamin supplementations and correlate with the clinical improvement. And the patients with the nutritional deficiencies or these abnormal gait associated with the vitamin and mineral deficiencies, they do well with the treatment. The recovery is good. And some diseases are incurable. In such situations, provide psychotherapy, muscle strengthening exercises in Parkinson's disease, and avoid stressful situations. To all these patients who are undergoing treatment for gait abnormality, because there is associated tremendous psychological trauma because of insecurity. So, all round care and support are essential during the treatment of these patients with abnormal gait. Well, prognosis depends upon the cause. Metabolic and the nutritional causes, they have got good prognosis. Thank you very much for patient listening. I'll meet you again in the next class. Until that time, this is Dr. Madhusudan Rao. Bye bye.